Hi everyone, this is Skylar Livingston. I'm here to talk about transmitted drug resistance for the Southeast AIDS Training and Education Center Clinician Mentoring Program today. So let's get started. So I'm going to talk about a lot of medications today, but I do not have any relationships with the pharmaceutical companies. And as part of Emory University's policy, I do not receive any gifts, even meals from farm reps. So our main objectives today are, one, very practical, incorporate systematic baseline HIV genotype testing into your clinical practice for HIV care. So that is something probably a lot of you are doing already, but that you should be doing systematically. Then the more challenging part, when you do get abnormal baseline genotype results, how is that going to affect how you adjust your antiretroviral therapy? And we'll go over some examples with that. And also, to really have expertise in this topic, of course, you need more than 15 minutes. A good place to start would be the Department of Health and Human Services guidelines, and there's the pages C11 to 16 for you, and we will share that link in an email as well. So like we talked about at the kickoff meeting, our goal is to get the viral load undetectable, to have the virus replicating at a very low rate, giving it minimal opportunity to develop resistance. And we have someone who's treatment naive, who's starting out. You can see in this graph, the baseline viral load is over 100,000 over log 5. And that in a successful case, we're seeing the viral load go down rapidly and becoming undetectable, in this case, after about a couple months. In your patients, it's going to take anywhere from 1 to 6 months to get undetectable, for folks who are taking their medication correctly. And transmitted resistance is one of the ways that this success story can be interfered with. The more common way is adherence problems, but transmitted resistance is important too. But as we touched on the last talk, from the best data we have, most recent data we have from CDC surveillance shows that in folks with new diagnosis of HIV, about 16% of them have some transmitted drug resistance. What we see most is the nrti resistance. So that's one to definitely have on your radar, and that's about 8.1%, as you can see. And also very important and perhaps a little trickier for management is nrti resistance at 6.7%. You can have multi-class resistance in some patients. And you'll notice that while there is a significant rate of resistance to protease inhibitors, the mutations that we see almost never affect boosted darunavir and boosted atazanavir. So you're generally in good shape with protease inhibitors. So when we talk about genotyping, we're actually doing gene sequencing of the parts of the reverse transcriptase and protease enzymes that are known to be involved in drug resistance. Sometimes we'll even test the integrase enzyme, but that is the type of test it is. It's quite expensive. And to give you an example of the results, when you have a mutation, the way that we talk about that is in this format. So a letter, a number, and another letter. So M184V is a common mutation we deal with. And what that means is that the wild type HIV virus, which is not resistant, has a methionine at position 184 in the reverse transcriptase protein, and that has been replaced with a valine in the mutant strain. So that's just understanding how the terminology. Again, from that same CDC data, we can break it down even further. This is not complete data, as you can see, but just some samples. In terms of nrti resistance, you can see that the majority of what we deal with is a particular mutation called K103N, and that's about 70% of what we see. And that's very important because it causes complete resistance to efavirenz and nevirapine, and as you know, efavirenz is part of the popular regimen A-triplet. In terms of nrti resistance, the most common mutation was M41L. We won't go into the details on that one, other than to say that it's a fairly mild level of resistance with just that mutation. You'll see that I mentioned K65R because that's a more concerning mutation. It's one that affects tenofovir, and we don't see it very often, so that's reassuring. We do wonder if we're going to see it more as we're giving people Truvada for pre-exposure prophylaxis. And as you can see, there's some protease resistance, but it doesn't tend to affect the drugs that we care about. So here's just an example of a normal baseline genotype. As you can see, for all of the many drugs listed, there's no evidence of resistance. When you look at this, you're also going to look down below to the line that says drug resistance mutations detected, and it will list any mutations that are found in the terminology of, for example, K103N, and we don't see that here. They also will list below that the novel resistance mutations detected. And it'll be a long list of mutations, and you might wonder what is that. It's not usually relevant. You can talk to your mentor about rare cases where it might be, but that's certainly for a baseline genotype. It does not matter. And here's an example of an abnormal genotype. So now you can see that there is resistance or possible resistance to multiple NRTIs and multiple NNRTIs. And then you look down below, and you can see that you've got multiple common mutations. So the K103N, the M184I, which is essentially equivalent to M184B, K65R. Actually, those three I'm fairly familiar with at this point in HIV practice. M230L, that's what I'm going to be looking up when I see that. Just a note on integrase inhibitors. When you do check for resistance to integrase inhibitors, you're going to be using typically something called, commercially known as the prime genotype. So the P stands for protease, R for reverse transcriptase, and I for integrase. And that will get you all three of the enzymes. And for us at our clinic, that's a send-out test. But in terms of the DHHS guidelines, they say consider baseline testing for integrase inhibitor resistance in select cases. And even that recommendation was a C3 recommendation rather than, say, an A or a B recommendation. So you may find experts who want to do this at baseline, but they're saying really you should only be checking it in select cases. What might that select case be? Maybe someone where you actually know who the infecting partner is and know that they were exposed to integrase therapy. So I don't think you're commonly going to be getting a prime genotype at baseline. Some mentors may have different thoughts on that. But the guidelines, do not push you to do this at this stage. There is documented transmitted integrase inhibitor resistance out there, but it's certainly not common. It may become more common with time. So, as I mentioned, sometimes I have to look up these mutations, and the place I'm going to go to do that is the Stanford HIV database. You can seriously just go to Google and write Stanford HIV. I've got the link here for you. We're going to share that by email. And this is a huge database of genotype results and clinical correlation data. We'll look at some results from that in a moment. So here's an example case. You have a 30-year-old male who was recently seen in the health department for syphilis and was found to have HIV on his test. The CD4 is fairly high still, so this is probably a fairly recent infection. The viral load is quite high, almost 1 million. And you can see on the baseline genotype here, these often take about a couple weeks to come back, but that comes back, and you see in this particular patient K103N and M184V. Two very common mutations we deal with. So actually multi-class resistance on the initial genotype. You also see some mild transaminitis. The patient has hepatitis B surface antigen positive, and he has a downtrending RPR. So here's an example. If you go to the Stanford website and you plug in M184V and K103N into that website, and we can look at that after the didactic piece, it'll actually give you a report like this, which is sometimes perhaps more accurate than the report you get from the lab. So I like to plug everything into this, and it shows you what you have high-level resistance to, what's fully susceptible, what's just low-level resistance. And not only that, but it gives you these comments that kind of make you something of an expert in the area. So we won't linger here for the moment, but drill down on the M184V mutation. So in Stanford, what it says is that M184I and M184V cause high-level resistance to lamivudine and emtricitabine, not to mention low-level resistance to abacavir. However, you can still use lamivudine and emtricitabine because they make the virus hypersusceptible to tenofovir, which we're frequently still using in this case, also AZT, which we sometimes use. And not only that, but this M184V and I mutation, they cause, even though this virus is resistant to drug, it actually doesn't grow as well as wild-type virus. Just continuing that drug in the presence of that mutation will actually cause about a 0.5 log drop in the viral load. So we'll often still use these medications in the setting of this mutation. So when you're choosing a regimen for this patient, when I see the K103N, I certainly want to avoid efavirenz. It would be, you should never give efavirenz in that case. So atriple is off the table for this patient. Technically K103N should not affect rilpivirine, so Complera might be an option, although the viral load is way too high for that, so you're not going to use that in this case. One thing to think about is when there's transmitted drug resistance, over time, what you see on the genotype may eventually revert back to essentially wild-type sensitive virus, because sometimes that grows better than the resistant strains. So if you do see someone with K103N, it's possible there might even be some low-level nrti resistance that was not seen on the genotype that may or may not be clinically significant. So it's not a huge issue, but it might make you avoid something like rilpivirine or raltegravir that has a low genetic barrier to resistance, knowing that maybe that nrti backbone is partially compromised. So I wouldn't say these things. I wouldn't say raltegravir is contraindicated, but you might think about other options since you have lots of good options. In terms of the M184V mutation, and this is one you really are going to want to know because you're going to see it again and again. We're going to prefer Truvada to Epsicom as our backbone. As you saw, the virus becomes hyper susceptible to tenofovir. Of course, we wanted Truvada anyway in this patient because of hepatitis B. And for the third agent, I really would prefer to use something with a high genetic barrier to resistance, typically boosted darunavir or boosted atazanavir. We wonder, maybe dolutegravir and Truvada would be an adequate regimen in a patient like this, although there's people who know more than me about that, but I think the verdict's probably still out. So for this patient, I'm typically going to use Truvada and boosted darunavir. Sometimes you'll see certain providers add an additional agent, so a fourth active antiretroviral to be absolutely sure. We won't go into the finer points of that at the moment. Again, we just talking about poor choices for the third agent here, and the common factor is low genetic barrier to resistance. Some fun concepts. So you have an untreated patient, you're having tens of billions of new viruses created each day, and the reverse transcriptase enzyme does not copy the RNA in a very faithful way, so that you have one mutation per replication cycle. So what we say is that actually every possible drug-resistant strain is produced every day in a given patient, even not on treatment. And so there's resistant virus there at very, very low levels, even in an untreated patient. And that's part of why we need 3 drugs. We typically need 3 drugs to treat our patients. But the good news is the vast majority of what's there is going to be drug-sensitive viral strains, wild-type virus. When you do a genotype test, it's important to know that it's only going to detect resistance that's present at greater than 20 to 30% of the viral population. So something like we talked about the fitness of the virus. So M184V, like we said, not a very fit virus. if that's transmitted, as the years go by, M184V will actually go to levels low enough that you won't see it on the genotype anymore. So just know that there could still be what we would call a minority drug-resistant variant there, probably not as bad as having it at a higher level. Then other mutations like K103N actually grow very well compared to wild type, and those will stay positive on a genotype test much longer, whether they're transmitted or acquired. And interestingly, in sexual transmission, it's usually only one strain that's transmitted. So actually, the genotype you get during acute HIV or during the first year of infection is actually going to be the most accurate genotype you can get on that patient. And I don't want to go into too much detail here because of time, but just an example of someone, if you look at this graph and you look up here, you see a wild type genotype at baseline, but actually they went back with a more sensitive genotype and saw that this patient actually had K65R, which is a pretty substantial resistance, and they got placed on essentially Truvada plus nevirapine. So you see that they initially had this big drop in the viral load, but then on repeat testing at 2 months later, now the viral load's going up again. They're having virologic failure, evolution of drug resistance. So now we also have K103N present. We also have M184V present. And then they, as you can see up here, they change the regimen to account for this, and the person goes to undetectable. This isn't going to be too common of a scenario, but it's just to say that not everybody with the normal genotype who goes through something like this, it's not always because of non-adherence. Sometimes there can be some background resistance that's contributing to failure. And then just one last point, I like to try to prevent acquired resistance if I have a patient that I'm not so sure of what their adherence is going to be like. I like to use boosted protease inhibitors to prevent them from developing a lot of resistance. Whereas something like a Tripla or Truvada or Altegravir, if they're on and off their treatment as they're trying to get it figured out, you may develop resistance in the process. There's the objectives for you again, but I want to move along to discussion. Thank you all very much for attending the didactic session, and now we'll move on. And here's my references for those watching the video.